Good evening, all, and a warm and enthusiastic welcome to our second live podcast. We're truly grateful for you joining us this evening as we delve into the realm of maximizing the potential of AI in endovascular surgery. My name is Joe Chan. I'm from Sidar Medical, and it's my pleasure to introduce this session. This evening, we have the privilege of being joined by two distinguished guest speakers. Returning to our screens is Professor Ross Milner, Chief of Vascular Surgery at University of Chicago Med, along with Dr. Catherine Lewis, Consultant Interventional Radiologist at Somerset NHS Foundation Trust. Their vast experience and expertise in their fields will absolutely undoubtedly provide us with invaluable insights. During tonight's podcast, we'll explore how these clinicians apply the power of AI in their endovascular practices. Specifically, Dr. Miller and Dr. Lewis will share their groundbreaking experiences with SIDAR maps, showcasing its applications beyond abdominal aortic aneurysm repair and how they seamlessly incorporate the software into other procedures. We strongly encourage each and every one of you to actively participate in the conversation. The chat box eagerly awaits comments, questions, even tell us where you're joining us from, as we're really curious to know where you are. So we really invite you to also share your thoughts, experience, and queries relating to AI-driven care in any healthcare setting. So please do not be shy. It's a golden opportunity to engage and share insights with fellow attendees. So without any further ado, I'll pass over to Professor Milner to kick off the conversation.
Great. Thank you very much, Joe, and thank you very much for having me back again. It's really an honor and a privilege to work with Catherine today. I actually had seen several of Catherine's really provocative LinkedIn posts about what she was doing with SIDAR. Then we had a chance to meet in person last month when I was at the Charing Cross Symposium, and it's always great to have an opportunity to meet in person, especially as we're all starting to really come out of the pandemic issues that we all dealt with. So, Catherine, great to see you again virtually, and I'm glad we had an opportunity to meet in person before we were doing this today.
Yeah, me too. Thanks everyone for joining, whether you're at the end of the day here and going off out to enjoy the sun later this evening, or whether you're still in the middle of work. And thanks, Ross and Joe, for the fantastic introduction. So it's going to be great to spend the next 30 minutes chatting about how when the technology now exists to actually perform a wider range of applications than the original plan for SIDAR to use with aortic. And certainly I'm happy to share some of my different cases and experiences.
Yeah, that's great. And I think that'll be the focus for today. And already, as a couple of you have, thank you for letting us know you're here and where you're from. We'll be paying a close attention to the comments that come in and questions. And we're looking forward to having more of a conversation than just me and Catherine talking to you. So please don't hesitate. Send in your questions, comments, and we'll try to highlight those. So I think, Catherine just made an excellent point. And for many of us who learned about SIDAR previously, we always thought of this as a technology that was going to help us specifically with an abdominal aortic aneurysm care or potentially thoracic aneurysms, and didn't necessarily think about some of the other applications where it would be beneficial for us. I think many of us that have used it for EVAR and for FEVAR or other complex aneurysm repairs have seen the benefit of reduction of contrast, have seen the benefit of reduction of the radiation exposure that we get and our patients get. But I think what we've learned is that we can expand this to our success beyond just what we've done with aneurysm care. So, Catherine, I'm going to start out with a question for you. How long now have you been using SIDAR maps?
So about 15 months or so we went live. And we're in a relatively big vascular centre in the UK, and we're probably, as everyone's seeing, the numbers of EVARs are starting to decrease, so about 30 to 40 a year. So although we do use it for EVAR, and we've experienced some of those benefits you've mentioned there about radiation dose and contrast reduction, I think naturally my inclination as an interventional radiologist is to explore what we could do beyond that. So expanding it more into sort of other procedures I do in my everyday practice, because when we're working with the surgeons doing the EVARs, those numbers are relatively small. So it's nice to be able to apply those technologies to other endovascular cases.
Yeah, that's great. And just I'm going to take a pause for 1 second, Catherine, just to highlight there's some people who joined us from the United States, but also from South America. So that's great. And looking forward to seeing where other people from different parts of the world are joining us. So, Catherine, you talked about this a little bit, but what procedures did you use at first? I mean, when you started talking about EVAR initially, what were the initial
Yeah.
procedures that you used?
So yeah, my plan was to use it predominantly for EVAR, but my very first case was just an iliac stenosis, obstructive occlusion, and we just wanted to get used to using the software, just to mark sort of the points where we were planning to stent and sort of in preparation for EVAR. And then my second case actually was a sort of an unplanned case, an emergency case, where sort of about 5 o'clock in the evening, at the end of the list, I took a phone call from a clinician in one of our spoke sites. So where we are is in Somerset in England. The distances are quite far, and we have a number of sort of smaller district hospitals which feed into us. And this was a pseudoaneurysm coming from a gastroduodenal artery. So it was a GI bleed in quite an unwell patient. And I could look at the CT from my office, and I looked at it, and there was this incredibly stenotic and quite steep sloping celiac axis. And I thought that's going to be a challenge to get into that, to get into the GZA, and I could see the bleed. And I just wonder if SIDAR might be useful here. And it's our second case, so I rang SIDAR support, and they helped me get the scan uploaded from the other side. And there was obviously 30 minutes or so for the patient to transfer hospitals before they arrived. So together we made this map where we just marked the celiac axis and the optimum angulation. And then by the time the patient arrived, that map was ready to go. So that was sort of an unplanned second case. And our radiographer had done sort of the initial online training, but hadn't used it. But it was very sort of intuitive and easy to use. So there was just marked, put a ring on the celiac axis and put the injection. And actually, it only took me 1 or 2 minutes to cannulate, which I was amazed about, and get into the vessel. So it wasn't a whole map like you had done for an EVAR, but it was really useful just for that case, and it definitely made the procedure easier. And also, I didn't have to. I used to typically screen lateral to see the celiac axis, but because I mapped it, I was able to go in an oblique direction, which is much easier ergonomically for the radiographer and the team, but also less radiation for the patient. So that was my second case was straight in there.
Oh, good for you for being creative about thinking about how to use it and in a different application than you initially thought it was going to be valuable for. And I think many of us have now learned, and I use it for mesenteric occlusive disease as well. You know, you put a little ring, you have an idea where you're at, and you can do a fair bit without even having to administer any contrast, which is valuable. So, Catherine, we also actually have somebody now that's joined us from your part of the world. So we have 3 continents represented now. Not bad. North America, South America, Europe. We're doing okay. Be nice. We can maybe somehow get somebody from Asia that showed up. I don't know if the time of day is going to allow it or not, but we'll see. Australia more likely. We'll see. But that's great, Catherine, and really exciting use of the technology when you used it for an acute case like that. And it also, I think one of the concerns that people have when they initially gain experience with SIDAR, but goes away as you obtain more experience with the technology is, how long does it take you to map? How long does it take you to upload films? And the fact that you were able to manage this in the setting of an emergency patient just demonstrates how quickly you can get the images you need and then mark what you want to mark for the patient. And I think you've probably learned that over and over again now, but it's good to share with the others.
Yeah, absolutely. I tend to, it's the uploading the map. I set it to go straight away. When I look at the CT, if I think I'm on the inside, I'll set it to go, do all the other arrangements, and then actually making the maps a lot quicker. And then we put that, the other sort of tip is to load it onto when you're in the OR, to load it up immediately. And once you do your checklist and you verify your patient, because then the map is there as soon as you start screening, it's ready to go, and that's really quick.
Yeah, Greg McGiff, who is well known to me because he does a lot of the SIDAR support here in the United States, just shared with us in public chat that he agreed that your case was a great case and that he has supported a case where SIDAR was used to assist with coiling the inflow and outflow of the saccular aneurysm, which is pretty impressive. So that's great to hear. So clearly people are using it more and more now for interventions other than just EVAR assist technology.
I think I've got a case actually. I think Joe, can you show the picture of these splenic aneurysms? It's a very similar case to that, which is an elective visceral aneurysm, where it's the one previous. Yeah. We use that to show, again, marking the left-hand side, marking the celiac axis, but actually there we've marked the inflow and outflow of the splenic aneurysm, and you do that by extending your vessel. You can see that 360 loop of the splenic, but you can still actually quite easily extend that vessel around, and then also make the measurements from that, and that's where I've landed my outflow and inflow coils and a couple of coils in the pack there. So I am using it also for that opportunity, which I think one of your colleagues in the US has described, and I've heard people using it for that commonly now.
Yeah, that's great, and really, the images are beautiful there, and it shows you how nice you were able to make that map work for the way that you needed it to work for that case. I took my headphones out. I don't know if my headphones were causing the echo or not. So if for some reason you can't hear me as well, let me know. But it seemed like my microphone from my headphones was creating an echo. So Catherine, you started to talk about this a little bit. With EVAR Assist, you're clearly already starting to say that you don't think that's the only use for the technology. And where else have you used it? You talked about this emergency case. We talked about the splenic artery aneurysm. I think I've seen you post online some use of this with aortoiliac occlusive disease as well.
Yeah, I have. So aortoiliac occlusive disease a couple of times now to mark the proximal and distal aspects of the occlusion. But actually what is quite nice about it is you can also then see your wire tracking through the SIDAR map, and you can even make sure you sort of manipulate your wire to the medial or the lateral aspects. And there was a patient, the case I used it on, which I posted, and I think you've seen, was a patient who I'd brought back. So the first time I'd been unsuccessful in crossing the lesion. Is a young patient with a smoker with quite long-term iliac occlusion, but really life-limiting symptoms. And so we planned to bring it back with a re-entry device, and I used the SIDAR for that. And it was actually, Joe, could you bring up the picture actually? Yeah, lovely. So I marked the occlusion, the rings on the proximal distal aspects, and there's in the middle, the pre-op, the initial angio. But also use the angulation of SIDAR to help get more of a 3D picture and direct the wire and the re-entry. And we initially, again, when we tried to cross it, went up the lateral aspect, but then we were able to sort of manipulate that and think, well, actually, no, we need to be in the medial side of that vessel, and we want to re-enter the bifurcation. And we did that controlled re-entry and then placed stents. So it was a successful procedure the second time. I think he's still doing well at the moment. That was about 6 weeks ago.
Yeah, it's great. And once again, just a great illustration. And I think one of the other technique points that you were just mentioning, for EVAR, intermittently, when you're trying to land in the distal common iliac and preserve an internal, sometimes it's a little challenging to see exactly where the origin of the internal iliac artery is. And, most of the time we'll have some reconstructed image ahead of time that we predict what our appropriate corrections are. But sometimes once you get a stiff wire up there, you lose it. And one of the things that I've done is use my map to help me, see where I can really see the internal and external splay out, and then wait to shoot any dye until I really have seen it on SIDAR that it's opened up. So similar to what you're talking about.
Yeah, I think that definitely helps you reduce your radiation and your contrast, because sort of all that planning and sort of the adjustment, you can just use the SIDAR, again with minimal DSAs or fluoro runs. It's also use more fluoro runs now to confirm the luminal patency just before you deploy stents. Actually being able to angulate in real time, as soon as you angle, the SIDAR map will move, and then you'll be able to see where your internal iliac origin, for example, is.
For sure. And then, Catherine, one of my sort of beliefs right now, my experience has been, I try to do similar marking to what you've done here. I think initially when you gain some experience with it, you realize actually having just a minimum amount of marking on the screen is better. You have your targets of what you want. And then I think when I first started doing this, I was putting rings around every little concept that I looked at. I'm like, I should put a ring here, I should put a ring here. And then I've stopped doing that. And it looks like in a case like this, you've done exactly that. You put a ring in your around your occlusion basically, and then you're done. So what do you think to date has been the most creative use of the technology for you?
So when I remember when I was introduced to SIDAR, and I was like, well, what else can I use it for? And it seemed natural to go to the visceral segment and the eye-led occlusions. And then I was like, well, can I use it for like prostate artery embolization? Because the anatomy is really complex with prostate artery embolization, and it's variable anatomy. So the prostate artery can arise from 5 different arteries in the pelvis of the internal iliac, whether it comes off the superior vesicle or the obturator or the pudenda. It's really quite complex, and I just thought, I just wonder, can I? And the SIDAR range now goes down to L5. So, and we do a CT pelvic angio with GTN for our planning. So on some of the largest PAEs cases, I have started now to map that, because when you're in the case, you often do find the high dose procedures for using a lot of contrast. And again, very targeting it. I tend to map my path, use it to extend the vessel, map the route and where the origin of the prostate artery. And I've only done a few of these, but larger vessels, the technology now can identify those smaller arteries, and quite accurately, I just put a small ring on the origin. And I wanted to see if I could do it. Thanks, Joe. Yeah. So this is one which was actually, I did bilateral, and that was off the obturator there. So what I've done there is with the internal is just map that, map the anterior trunk, map the obturator, and that tiny little red ring is the origin of where I thought the prostate artery was. And then we've got a microcatheter in there. So we're talking, these are 1 or 2 millimeter vessels now. And it was completely accurate, and I wasn't sure. I didn't even have to do a map adjustment here. And then we can see on the picture on the right, actually, the microcatheter is in the prostate artery. So this, I think this is a game changer potentially for interventional radiology, because this is the question people ask. My IR colleagues, they say, well, can we use it for prostates? So you can. It's the field of view isn't quite there yet, because you have to have L5 in initially. So you have to make the map with L5, and then I tend to cone right down. And if you cone down, you're reducing the radiation, you still maintain your map. But it is a bit variable. If you move, you have to then put L5 back in. So in the future, who knows? But it was incredibly useful, and that's a procedure which used to take sort of 2 to 3 hours, is now taking me about an hour and a quarter.
Wow.
So it's a really big difference. And it can take, you can be there for an hour trying to cannulate a prostate artery. So to be able to get in sort of 7 or 8 minutes is really useful. So
yeah, that's amazing difference, Catherine. And I just wanted to highlight a point that you just made a second ago. For those of you who maybe don't have as much familiarity with the technology, if you see here, the outline of the blood vessels are yellow. And on the prior example that Catherine showed, the outline of the vessels were blue. So what that demonstrates for you is when it's yellow like this, it means we haven't adjusted the map at all. This is exactly the map we've achieved ahead of time from the 3D reconstruction from the CT scan that we have. And then at times we'll take images that we realize that we want to adjust the map, which we commonly do for many of our cases. And once that map's adjusted, the outline turns blue, but it stays consistent. Whichever obliquity you're in, cranial caudal correction, it doesn't matter. It continues to correct with the adjusted map. So I think it's just good to see the difference. And you made a point here to specifically say that you haven't even needed to adjust the map to be able to do what you needed to do here.
Yeah, it was surprisingly. I'm always surprised, pleasantly surprised. I mean, it's incredibly accurate. I mean, I'm noticing that positions of stents and the aorta are very accurate. You look at the follow-up CTs, and actually the software off that CT, the anatomy, the pelvis, and also with here this we're not using stiff wires. So I think in EVAR we have using stiff wires, and we have to therefore do map adjustments with definition of anatomy. But often we're not using stiff wires. By the time we're actually into the internal, we're using hydrophilic wires and we're using microcatheters. So it's really exciting, and I think we've seen when SIDAR came out, all the different versions coming through. So when I started, the software was version 105, and every 6 weeks it updates, and then we've seen them expand into the chest to go from sort of T12 now up to sort of mapping for thoracic and T6. So I think like when we're talking about development, and I know there are lots of different development teams now working on different things. So to be able to develop that inferiorly into the pelvis, I think for iliac work would be, and for this type of thing, perhaps using bony landmarks will be certainly an area to watch. I'm just speculating at the moment, but it will be. There's a lot of procedures.
Yeah, that's great. You'll laugh at this, Catherine. Greg is commenting again. I think he wants you to work harder. He wants to know, with the reduction in your procedure time with the PAEs, are you able to add additional cases on that same day? I think he's trying to tell you he doesn't think you work hard enough, Catherine.
No, but there's always enough emergency work. So yesterday we had a PAE and an iliac case and a colonic. There's always lots of work. My days never fill. I never get to go home that early. But I think what it does though is it takes. Yes, and that's the business case really. That actually, if you can prove that you shorten procedure time, you can fit more patients in. But also looking at these CTs and trying to get that mental image with prostates. And I used to, when we started doing this, we did this as a 2-person team. And, as our learning curve, we've been doing about 3 years of prostate. So you have a second pair of eyes when you do the CT and to help you, who could refer back to the CT. Because I used to draw little pictures and then stick them up on the wall. And that's my map of where the prostate artery comes and what angle. But actually, SIDAR takes some of that cognitive burden away from you. It does the sort of hard bit of the job, and that map's there. So I feel less mentally drained, and it's difficult to measure this, but I think that's one of the other sorts of benefits of the procedure, that the data processing which is going on and the computer machine learning in the background is doing some of that really intense sort of cognitive work for you. So it allows you sort of more bandwidth to make judgment decisions, clinical decisions, interact with your team, interact with your patients. I feel less tired at the end of a case, I think, like this. And we do, we've certainly do now put sort of 3 EVARs or on a list, 2 EVARs and venous stent. We are beginning to actually see the benefits of that coming through.
I think that's right. And I think the other part of it, which we highlighted a little bit earlier, but I think it's good to reinforce. I think it's not just that you're able to get 3 cases in a day now, potentially, which you weren't able before because of how the case is expedited, but you're also exposing yourself and your patient to a lot less radiation, right? So even though you're doing an additional case in a day, I bet when you look at your total radiation exposure, it's potentially less than it was when you only did 2 cases in a day.
Yeah. So I've looked at my EVAR data in post-SIDAR, because we had a large database of our for a study which has been done in the UK. Actually, we'd already looked at our sort of 2.5-year data of EVAR pre-SIDAR, and I have definitely noticed, our procedure time is down 40%, and our contrast and radiation down about 30%. Obviously, the numbers are small at the moment, but the trend is that they're likely to be really significant. And again, with prostates, as that carries on, and with other cases, once I've done more of those, then we can start looking at those and seeing how much that benefits, because it's with those radiation doses coming down, and also for the team as well, because we've got
absolutely
exposed, and actually in IR even more every day we're doing radiation procedures, and our radiographers are getting exposed and we're getting exposed. So I think that's a real benefit. So I'm working with, you can use SIDAR in combination with other techniques like IVUS, for example, to really kind of bring those doses down even more. So intravascular ultrasound, we're talking about when I say IVUS, for any medical students and trainees watching. So that's another way we can get use it in combination to mark, for example, where stenosis is externally with the SIDAR, and then look at it internally with the IVUS to see what the stenosis is like, size the vessel, and reduce our screening time.
Yeah, that's great. So, Catherine, I'm going to interrupt you one sec. So, just for the audience, we just have a few minutes left, and be happy if anybody would like to. Obviously, any questions, we're happy both of us to answer. And the other comment I would make is anybody has any unique experience with their use of SIDAR, we would love to share that as well. So please don't hesitate to comment, and we can see your comments here if you'd like. But if anybody has any questions, we're happy to take a look at it. So, Catherine, other procedures at all that maybe you do, are you involved? You mentioned the prostate. Do you do uterine embolization stuff as well, or?
Yeah, I do, and that's interesting because again, you think that would be the ideal patient group. It's a young patient group. To do, the arteries are quite big. I think you could certainly map them, but the problem is with that is that we plan them because the vessels are larger. I plan them using an MR angiogram, not CT angiogram. So the SIDAR is only, it takes the CT and overlays that as the image fusion from that. So I do think the benefit is there to expose a patient to having a CT for planning for uterine artery embolization, which is a radiation dose, to then use over SIDAR. But if ever any technology found a way to map MR angiograms, there would be, again, something to consider.
Yeah, I wonder, and I don't know the answer to this because it's not a procedure I typically do, obviously. But when you balance the length of the procedure or radiation exposure in a procedure versus then getting the preoperative CT scan, how that would balance out, and I don't know. I mean, it sounds like it's relatively normal vessels for you, and maybe isn't that difficult, but it would be interesting to sort of look at that and see what the total radiation is with a CT and then a procedure, or just the procedure.
Yeah, we could capture similar CT data from similar cohort of patients on to and average doses and work that out. Our doses are quite small, I think, for younger patients. But I mean, I did have there's patients who have renal impairment as well. It's useful to use for that. And I had a young patient actually had a renal angiomyolipoma I embolized, and again I use LiDAR to help map out the artery feeding, the AML, and reduce the screening time there. And she was in her 30s, so there are applications for it. The more you do, the more you think, wow, this could be useful there. And always thinking, how can we make this safer and more accurate and a better experience?
Yeah, absolutely. Catherine, I can't remember, did you have images for one more case that you wanted to share, or was it?
I have an example for venous occlusion, actually.
Yeah, that'd be great. We're like less than 2 minutes left here, but bring it up. It'd be great to share it.
Because this was a chronic venous occlusion. So on the CT, the vessel was slit-like a pencil line because it was chronically occluded. So the way we mapped the venous case there was to put a series of marker dots, which are all those circles are. So it is a bit more busy than my usual planning, but I've mapped the course of the venous occlusion, and then the red circles are the sort of landing zones to place the stent if we were to cross it. So again, even with not being able to have contrast in the vessel, and this was actually a portovenous phase scan, not an arterial scan, we were able to make a map, and you can see the curve in those dots. And actually, when you look at in the middle picture, the stent being placed and the wire tree, you can see that actually how that wire and stent has taken the curve, almost exactly matching those dots. Again, that's an unadjusted map. So it was incredibly useful to see your wire going through the dots and be reassured that you hadn't caused a wire perforation or that you're making track through the occlusion.
That's awesome. That's great. Well, Catherine, your creativity with using SIDAR is spectacular. It's fun to see, and I hope the others who've joined us have enjoyed seeing it as much as I have. But really appreciate you taking the time and for the two of us to be able to be here today, and hope everybody enjoyed our conversation. And I'm going to turn it back over to Joe to close us out.
Thank you.
Thanks very much. Thank you, Professor Milner. So, yeah, reached the end of today's podcast and seeing how these guys make the most of AI in their practice. And before we part ways, we just want to say a huge thank you to our speakers, Professor Miller and Dr. Lewis here. The insights are truly enriching the discussion and really advertising how much can be done using AI and with a bit of creativity too. And a big thank you also to our audience. Thank you for joining us from wherever you are. It's probably not the most favourable of times in every time zone that we're accessing this evening. So, as we wrap up today, so just like to really encourage you to keep an eye out for our future installments. Together, we'll continue this remarkable journey of exploration, delve further into these vast capabilities of AI, and the exciting possibilities that lie ahead are truly bound to leave us in awe. So thank you again. Until next time, stay curious, stay engaged, and we hope that you keep embracing and applying the remarkable potential of AI. Good evening, all.
Leaving. Bye,
Thanks,
everyone.
Joe. Bye bye.
Thanks, John.